Good afternoon, everyone. We will get started here in just a few minutes. I'm just waiting for a few more people to join the call. If you are a committee member, if you would put your name in the chat. If you are a committee member who is only on the phone, please unmute and let us know that you are here. We should get started in just another minute or two. Thank you. Again, thank you for those who have just joined us. We'll get started here in just another minute. If you are a committee member, please put your name in the chat. If you're a committee member who's on the phone only, if you would unmute and let us know that you are here. Rachel, I am seeing that we just barely have a quorum, so you can get started if you would like, or if you want to wait just another minute for folks that are still joining.
We can wait one more minute. I think that's okay.
Yeah, that'd be great. Thank you.
Also, my apologies. My computer is not working, so I'm on my phone. I'm going to try and switch, but that's why I'm off video. I'm sorry.
Yeah, so Rachel, whenever you are ready, we do have a quorum, so you can start whenever you are situated. Thank you.
Awesome. Welcome everyone to our June Medicaid Advisory Committee meeting, and happy Juneteenth. I appreciate those that might be working when you have the day off. So thanks for being here. I will first take a motion to approve the minutes from April and May. If anyone wants to make that motion.
Hi, Rachel. This is Davis Moore. I can make the motion for both the minutes of April and May. I've reviewed them both.
Thank you. Do we have a second to that?
I can second. This is Joey.
Thank you. And as usual, we will vote by silence. So if anyone has any issues with opposing that, please let me know. Otherwise, we can consider those approved. Also, I'd like to welcome Joe Hirabayashi. Joe, I hope I said your last name right. I realized I've never said your last name out loud before.
You did.
Thank you. Joe is stepping in for Alan Ormsby, who is I might mess this up, Sharon, so you can correct me, the senior consumer representative on the MAC. Alan has a meeting at the same time, so Joe so graciously filled in. Joe is the advocacy director, and also correct me if I got your
Spot on. Thank you.
role wrong at AARP. Joe, if you want to introduce yourself at all, feel free to take this time, or you don't have to. It's up to you.
Sure. I'm Joe Hirabayashi. I've been with AARP for about a year and a half. And as Rachel mentioned, Alan would love to be here, but he's on a conflicting call with our internal DC office. So happy to join.
Thanks. Welcome, Joe. We're happy to have you. And then Sharon, remind me, was last month Steph Burdick's last MAC meeting, or is it this month?
It was last month. Yeah,
Okay.
It was last month. So we thanked her in the May meeting. So.
Oh, awesome. Okay, I forgot I wasn't at the May meeting.
Yeah,
I'd like to personally thank Steph too. Steph, I don't know if you're on here, but I want to put it on the record and have it on the record that I'm very thankful for Steph's work on the MAC. And I'm sure she'll still be joining us, but I will miss her nonetheless. So I think for number 2, Sharon, do we want to do this now? Has everyone voted, or do we want to push agenda item number 2 to the end if anyone else needs to vote
No.
on the budget recommendations?
No, you go ahead and do it now. That way, if there's
Okay.
any questions or discussions anyone wants to have, but if you have not voted yet, please do so by the end of the meeting. It is still open, so those who have not voted yet can still do so, and then I'll read the results at the end.
Awesome. Okay. So as Sharon said, all of you should have received a both a spreadsheet and a link, either or works, to vote on the MAC budget items that were presented during the May MAC meeting. Does anyone want to have any discussion, or does anyone have any questions? I know we don't probably have all the presenters here, but any discussion we can take now on those budget items. And then if you haven't voted, please take time during this meeting to vote before the end, so we can get everyone's votes in. Okay, hearing no discussion or questions, I think we can move on to agenda item number 3. But I just want to reiterate to please vote if you haven't already. Sharon sent out a reminder, I think yesterday or the day before, to those of us that didn't vote. I was included in that. So if you got that email yesterday, and still haven't voted, please vote. But I will pass it off to Daryl for agenda item number 3, which is an update from the notices committee.
Great, thank you, Rachel. So the notices committee, we're continuing to review standalone notices. As of today, we've reviewed 60 standalone notices. 26 of them we have reviewed in the past 3 months. So these are notices from tax filer household composition forms, changes in review dates, Medicaid decisions, and lots of other big and small notices that go out. And the committee is looking at these notices to make sure that they use plain language, that they're easy to understand, that some of the important sections are being pulled out and highlighted, as well as being explicit about when dates and verifications are due, and including contact information and business hours from DWS. So still actively working through a long list, and I just want to say thank you to Gina Boren and the other staff that joined the call for actively listening to the committee's input and for helping to make some additional changes for the better. So thanks very much.
Thanks, Daryl, for that update. Does anyone have any questions for Daryl or perhaps Gina? Hey, hearing none. Thank you again, Daryl. I know that and Gina and everyone else that serves on that committee. I have a conflict during that time, so I haven't been able to make it, but I know it's a lot of work. So thank you. Agenda item number 4, we'll get an eligibility and enrollment update from Michelle.
Yeah, hi, Rachel. Thank you. Sharon, if I could, yeah, thank you. Just take over. So I will review the Medicaid enrollment report. And as always, drop this in the chat because this is available on our website for any of you who'd like to go in on your own and look at more than what I will cover today. I will focus, as always, on the persons tab. So up at the top, there's cases, persons, children, adults. So I'll look at overall persons enrolled, and our current, as of May, get it back over there, May 2025, current member count is 351,649 individuals total. If you look over here, you got this interactive graph that we're looking at right now, or you can click on the data table and kind of drill down more into the different coverage groups. I did look, nothing really stands out in terms of anything significant between the programs that I could tell. I think the same trends that I pointed out previously, it looks to be leveling out with pregnant women, but so nothing significant there. CHIP, still slight increase from unwinding with children moving from Medicaid over to the CHIP program, but that seems to have kind of leveled out as well. So nothing significant really to point out there. I will move over to our eligibility data dashboard. Again, this is also available on our website. I'll drop this in the chat. This gets updated every month as well with outcomes for renewals on this first tab. So up at the top, I'm focused on the review outcomes tab. And if you hover over this last bar, we still have a high rate of completing renewals through ex parte. So close to 39% of the renewals were completed through ex parte in the month of May, which is really good. We are still seeing that pending number increase at around 15%. This is a direct result of the policy that we implemented in January of this year out of the eligibility final rule to improve transitions between programs. So I think that's a really good, data point to point out. And then up at the top again, for those of you who want to go in on your own, this first tab or the second tab, Medicaid to CHIP, just shows some of the movement. That's kind of leveled out. This members tab just shows, new members, any returning members over the last 3 months. So anyone who lost coverage and then comes back within 3 months, that's the returning members. This other DWS eligibility activity, you can see the month of May, and I can't really explain this, but it shows the applications dropped quite a bit from the month prior. Not quite sure why, but that's probably the only significant change there to point out. This tab, other DHHS eligibility activity, this is our presumptive eligibility. You can see, where we're at in terms of how many applications are coming in through the hospitals through presumptive eligibility, and then our baby or baby clinics. And then DWS call volume is pretty steady. The calls kind of increased in the month of May. The call wait time seems to be remaining pretty steady at around 16 minutes. And the abandonment rate at 20% currently. Another dashboard that I know that we've talked about before is the LEM 15 waiver dashboard that was requested. I won't really take time to go through this, but just want to make it known and available for you all. So I'll drop this in the chat as well for those of you who want to look at this on your own. But this first tab shows the programs that are within the LEM 15 waiver, and the enrollment data for eligibility, and then the benefits and kind of the trend for the benefit data under the waiver. So I will stop there and just ask if anybody has any questions for me.
Michelle, I do, and this is just kind of like a follow-up, and you might not have the answer yet, but I had asked, I don't know, probably like maybe during the April MAC meeting or March, about the definitions on like pending application and what happens if an application, where an application that just isn't like approved or denied Medicaid, but instead is closed due to like that kind of procedural closure definition, where that falls in the like days to decision definition. So do you guys ever figure that out?
No, but Rachel, that is something, that's a little tricky and definitely
For sure.
will need to work closely with Department of Workforce Services, but on that data point. And I know Melissa Presley was kind of going to be in and out of this meeting today, so I don't know if she's still on, but I can get with her after, and we will follow up with you before the next MAC meeting. And we may reach out and maybe schedule something to talk through that with you. But and actually, I see Melissa. I don't know if you're able to talk. Melissa, sorry to put you on the spot.
No, that's fine. That'll be
Okay.
an action item for Michelle and I, Rachel. I can't give you a definitive answer just because it does vary to some degree. So I think we could talk that through. But yeah, Michelle and I will take that on as an action item and follow up.
Well, thank you guys. I appreciate it. And I'm kind of just thinking out loud here. I wonder if that may drop in applications is because some folks are perceiving the proposed Medicaid cuts as actual Medicaid cuts. I wonder if people are like, well, I'm not even going to apply because the messaging that I'm hearing is that Medicaid's already been cut, like kind of like that misunderstanding, rightfully so, about a really complicated process. So that's just me thinking out loud. And that's not like something I think that's probably something advocates, I include myself in that, could do better about maybe assuring people that none of these cuts have actually happened yet. But that's just me thinking out loud.
Okay. Yeah. No. Yeah. We'll definitely take that back, and we may reach out to Rachel just to get some clarifying points. But we'll work with you on that.
Cool. Thank you.
Thanks.
Anyone else have any questions for Michelle? Okay. Hearing and seeing no questions, I think we can move on to agenda item number 5. Thank you again, Michelle. To an update from Colby on the Beneficiary Advisory Council, or the BAC.
Thanks, Rachel. We met for our first meeting for the Beneficiary Advisory Council last week. We had two member participants that either had a child or were a member themselves. And we essentially asked them coming to the meeting to be prepared to talk about 3 topics. We asked them, what areas of Medicaid interest you? Are there improvements for the program that we can look into? And then what experiences have they had, good or bad? And we had a really thoughtful discussion with these participants where they gave some feedback. They also expressed a tremendous amount of appreciation for the program, but then also gave us some ideas to take back and consider. Are you interested in hearing today what some of those ideas were? Or I'm not sure how much of an update you wanted from me, Rachel.
I think, I mean, we're pretty ahead of schedule. So if you want to share some, I think that would be good.
Okay, perfect. We had one mother who had an adult child that was trying to transition them from a pediatrician to a general provider. And given their circumstances, she needed a more narrowed search ability in trying to find a new provider. And so her feedback was helping parents more easily find a provider through some sort of tool where they could have keywords that they could search, like taking new patients or a specific specialty. And then she also talked about potentially having like a liaison for parents, somebody housed within the department that could potentially handhold through some of the maybe difficulties that they had in either like finding a provider or help with a care plan or getting prior authorization or approval for specific coverage of different services or medical supplies. And so that was some good feedback for us. And how can we do a better job in really supporting enrolled members? That was one set of feedback that I have. And then the other thing that we talked about was how do we recruit more participants, because that is ultimately our goal with this group, is to have a broader discussion with members in this can be ongoing, that we can continue to get feedback and then refine our processes and supports for members. So if you have recommendations or referrals that you can make to us, we would love to encourage more folks to join us on this next call, which will be, I believe, in 2 months. They are quarterly.
Thank you. So, Colby, my question is, so when you get these ideas from the back, or how do you like evaluate, and then if it's possible and something that is doable, I think, within your department, how are they like implemented, and like who like owns that at DHHS, like staff wise?
That's a great question. We are just at the beginning of implementing this council, and I don't have an answer for you today. It's something that we can certainly get back to you for the next SMAC meeting of what our process will be once we take these ideas and this feedback and how it will be moved forward. So let me get back to you on that, Rachel.
Cool, thank you. I appreciate that. And then I just want to remind folks on here to send out those back flyers. They've been sent out a couple of times now to us, so I think everyone should have them in an email from Sharon at this point. And if anyone needs them, either ask Sharon or ask me. I know I have one actually saved on my desktop. But be giving those out to people as you talk to them that may be good fits for the back. We know that it's tough for consumers a lot of the time to find that time, but if someone is interested and does, make sure you're letting them know. I've actually printed some off and given some to like strangers I've met in like restaurants and stuff before. So you don't have to be that weird about it, but if you know anyone, I think it will be appreciated. Any other questions for Colby, either about any of the BAC's meeting, or just about the BAC in general? Okay. Hearing none, I think we can move to agenda item number 6, which is Jen Strohecker's director's report. Thanks, Jen.
Okay. Yeah, thanks, Rachel. Hi, everyone. I hope you're having a good day. Thanks for joining us. Wanted to just go through a couple different items. I guess we'll start with budget reconciliation. This will be a longer part of the discussion, but I wanted to give you an update. This is kind of a sequential update here. We have presented to you earlier the budget reconciliation proposal that came out of the House today. We're going to really focus on an update of the Senate's version that was released earlier this week. But I'd like to just start with a bit of a backdrop. If we could please just to revisit what is reconciliation. So, and I apologize, let me get my laptop set up here. Thank you, Sharon, for presenting, by the way. So first of all, reconciliation, I think it's defined here on the screen, but it is a special legislative process that really has allowed Congress to fast track legislation related to the federal budget. This is specifically looking at a target of an $880 billion budget reduction. And one of the key items in order to achieve the reduction of that target of $888 billion is focused on some significant changes in the Medicaid program and in other places as well. But today we will be talking about changes that have been proposed on the Medicaid program in order to hit this budget reduction on the federal side. Next slide, please. So there is a journey that this bill has certainly followed over the last few months now, as it was originally proposed and then eventually passed out of the House. And we've presented this in past sessions. On Thursday, May 22nd, after it was voted on by the House and passed the House vote, it went over to the Senate. The last few weeks, it's been sitting in the Senate, and the language has been modified just a little bit from what was released released by the House, by the Senate, and that was released this past Monday on June 16th and sent back to the House for consideration. I think there is an interest in wrapping up the One Big Beautiful Bill Act by July 4th. And so we know there is active conversation ongoing right now around what the Senate has released and what that final proposal may look like. Now, there's no guarantee that there will be a final bill that is voted on and passed out of Congress by July 4th, but I believe that is the target date that Congress is seeking at this point. Next slide, please. So I think one thing too, and this is just a summary with hyperlinks of what was passed in the House version and in the Senate version. Today, we're going to specifically focus on some changes that came out that were different from the Senate bill, from what the House presented. And while I have a higher level overview that I'll go through, our slides do have more comprehensive information contained in them. It has a lot of text, but we will share those with the MAC afterwards that do kind of summarize these changes. And we are also now, the team has been certainly working on an analysis of how these specifically affect Utah. I will not be going into that today because that analysis is not completed and has not been finalized at this point, but we can certainly talk about various aspects of the language as it has been proposed. Next slide, please. So I think specifically looking at a higher level, I've highlighted some text in yellow to call out expansion. There are four significant changes by the Senate presented on this slide. One is looking at provider taxes. So originally, provider taxes today have a ceiling of 6%. Utah has 4 different provider taxes in place: nursing homes, intermediate care facilities, our hospitals, as well as our ambulance providers. And what other language had looked at, the update, I guess, that has been put forth by the Senate is that this would freeze provider taxes at the current level in all states. So you can't go up if you're below 6%. You can't then just submit new things to get up above that. You're going to be frozen at the current rate that you're at. And for us as an expansion state, what they are looking to do is to lower the tax ceiling that is currently in place at 6% and bring it down to 3.5% for all providers except for nursing homes and ICFs. And so for us specifically then, this would be targeting a reduction in the provider tax ceiling from 6% down to 3.5% for both hospitals as well as ambulances. And I know for ambulance providers, we are certainly above that 3.5% right now. And I believe for hospitals, we are actually maybe possibly just above that as well. And so that would have a direct impact on Utah with this change. There are other slides that I won't walk through, but I'll just say this reduction wasn't meant to happen all at once. The way the Senate has proposed this is that there would be a phase down in the tax from your current limit where you are today, wherever that is, up to 6% for different providers. And certainly other states have broad taxes on many different provider types that Utah does not. But it lays out a reduction over time to achieve that 3.5% ceiling. And so that was called out in the Senate language as well. So this is new and different. We're still evaluating how that would impact and interplay with some of the other proposals that have been put forth. So the second proposal that we have here that was put out in the Senate language was the state-directed payment provision. So for expansion states, this would cap a directed payment at 100% of Medicare. So how does this affect Utah? Today, Utah has a state-directed payment provision that is above Medicare at the average commercial rate, for example, and this would require us to reduce that over time until we got to that 100% of Medicare ceiling. And so this does actually, this description here does say that it requires already approved state-directed payments. So for Utah, it would take our already approved directed payments and reduce them by 10 percentage points annually starting in 2027 until they are no greater than the Medicare rate. So that would require a step down over time. For us, it would be a number of years that we would do that on our state-directed payments to bring them down. This would directly certainly affect our hospitals who are getting a state-directed payment, and may have a similar impact to some other payments as well. But specifically, this would have a direct effect on hospitals. So what are we thinking about with both the provider tax and the state-directed payment? Certainly, we see that there is an associated impact. Hospitals would be directly affected by this. And that certainly is something we're analyzing, evaluating impact. I'm sure I see Michael's on the call as a representative and a participant in Utah Hospital Association. He may want to speak to how the Hospital Association is looking at this, but also a specific rural hospital effect as well. And I think there's been some published media that's looked at how that would potentially impact rural hospitals as well. I will just note that there has been discussion that in order to kind of moderate this, that there has been some discussion that I've been aware of, that there is a rural hospital grant proposal in the work that will come out, that will be released in future days and or weeks, that may sort of offset these proposals a bit. But I don't have any other details than to say that that is there. But this would certainly affect our ambulances and have a direct effect on our hospitals, and potentially have a corresponding some effect as well as on our nursing homes. We are analyzing that. I don't know if I want to pause real quick and if others want to comment here or have anything to add, but we know that this would have a financial impact on our providers. Okay, moving forward then, I would just say our hope is to have an analysis completed by the end of this week. These are really tricky analyses because you're looking at many different things happening at once. We're, estimating what the Medicare payment rate would be, as well as estimating what the average commercial rate would be, and looking at sort of this phase down over time. So these are not really straightforward things that our analyst group is working on, but we aim to have them completed hopefully by the end of this week, and we'll certainly distribute them to lawmakers and our congressional delegates as soon as they are completed. And I'm going to dive into more detail into the work and community engagement requirements in later slides, but some specific differences that we'd like to call out in the Senate bill versus the House side were that there were changes to the exempt population. In originally, the exemption applied to any parent caretaker of a child and didn't specify an age. We see more defining language come forth in the Senate bill where it looks at a parent caretaker for children ages 14 and under. There's also a new optional exemption for travel to medical care that was inserted. There was also an extension. There was a lot of discussion around timelines for implementation. We still see that timeline for implementation of mandated work requirements across the adult population would be by January 1, 2027. However, there was a proposal to allow CMS to have an extended implementation deadline for states that met a good cause waiver exception that was approved by the secretary. So there was an extension for states that were putting good faith effort into implementation, and there is an option to extend that. There's also some language around a conflict of interest provision. I'll go into more detail on community engagement requirements and where we are with that in future slides. And then just to also note that in the prior language, there was actually a limitation here on retroactive coverage that, and it shrunk it down for expansion to only allow 1 month of retroactive coverage for the adult expansion population and 2 months for all other eligibility groups. So we're seeing here a step by the Senate to say we didn't go far enough with the House bill, and they're certainly looking to further increase, I guess, the savings that would be pulled out and the CBO analysis of savings through this bill. And so this are really the largest provisions that are coming out of it. And I'll spend a little bit more time going through these in the next slides. Let's go to the next slide, please. Other things that we're seeing as well is in the Senate bill is significant new provisions around health coverage for immigrant populations. So some changes that we see here is that historically covered groups that have been eligible for Medicaid under our current policy, that there are new limitations placed on these groups. And also some changes in the federal match around these emergency Medicaid and the interplay with immigration status for those who may qualify already for the expansion group. So again, looking at coverage for immigrants and sort of what we have in place today and looking to further refine that. We have a slide later that will go into greater detail. I may let Michelle lead out on this one. Also to call out as a change on the Senate bill is that these are smaller items, but certainly you're seeing here some other things listed. I won't take the time to go into them right now. Next slide, please. Wanted to dive in a little bit more to work requirements and the community engagement requirements. And again, there's a lot of text here. Some of this is a duplication of what I've already said, but we want to be thorough in what we're representing here. And then I will, after I'm done with this, I'll talk about our own waiver and what we're thinking with regard to the status of our own 1115 waiver around community engagement. So looking at the Senate provisions here, again, just to reiterate what I'd already stated, is that they still have this deadline of December 31st, 2026 and or January 1st, 2027 implementation, which is a mandated implementation for eligible adults. Now for us, I want to just call out the difference here is that this includes expansion and TAM populations, and we are evaluating other groups as well that would not meet exemption status, but they are eligible adults, with the option for an extension with states that meet the good faith effort and are approved by the Secretary. Want to call out too that this applies to 19 to 64-year-olds. Who are enrolled in the expansion group and enrolled in waivers as well. So looking at sort of that more comprehensive coverage around the population that could be categorized as working adults. We have a list of the mandatory exceptions and the optional hardship waivers that have been called out. We find, fairly good alignment with what we had looked at in our proposal, as well as what's this, not a whole lot of changes sorry, I'm going back and forth here, but the bill that was put forth by the House versus here, not a whole lot of changes besides those that I had already covered. Go to the next slide, please. The compliance standard has stayed the same with regard to how someone meets the work requirements. This has been consistent as it's moved through the different versions, that the individual must meet the requirement by working at least 80 hours a month or completing other qualifying activities, which could be community volunteering, could be schooling, or a combination of these. There's also the ability to look at monthly income and do a calculation of monthly income and estimate to say, well, you might not, working a number of hours or a dollar amount earned that is at least 80 times the federal hourly minimum wage. So they're looking at, are you earning at least minimum wage at a context of working 80 hours a month, and being able to capture the data that way. Now, one nuance that was placed in this bill was the fact that it allowed a provision for an earlier implementation of this community engagement work requirements via an 1115 waiver, where states are not under state plan authority. The way we envision the work requirements in this OBBBA is that it would be a state plan amendment, but they are allowing states to work under an 1115 waiver to have an earlier start date. We don't have a lot of detail what this might mean. Do you run a different program? Do you run the same program? We certainly know Georgia, for example, already has a plan in place. Other states have submitted waivers, but for us, we see that that's certainly something they put in as a pathway. Not going to go into a bunch of this other detail. Go ahead, team. If I'm missing something you feel is really important to call out, please do so. But if we could move to the next slide, please. And we'll go in. One other piece I'd like to call out is the funding. There have been grants that have been set aside as part of this legislation that look at $100 million distributed across states, and that would be used to help with some startup costs and getting the systems and programs and supports in place. So there has been a provision for grants. Next slide, please. Okay, I'm going to pause there quickly and just quickly talk about the Utah 1115 waiver and call out something I didn't mention earlier. One of the way that the bill is drafted implements community engagement requirements at the time of Medicaid application. And so as you look at the bill that is working through Congress, one of the major differences between the Utah version and the version that's moving through Congress is timing of work requirement provisions. And for example, Congress requires that before you even get Medicaid eligibility, you must fulfill these work requirement activities or qualify for an exemption prior to even getting in the door to become Medicaid eligible. The proposal that Utah has drafted is certainly looking at aligning with our SNAP program that allows someone to get Medicaid coverage. And after being approved for Medicaid coverage, at that point, we can then, interact with the member and with even their medical claims and some of their qualifying activities to be able to gather that data and then help support them in this process of fulfilling the work requirements. So when we look at where Utah stands today versus the congressional proposal, really our main focus today in engaging with our congressional delegation and also even through our NAMD channels and others as we're meeting with public stakeholders is to really emphasize this difference. I think the Utah proposal has been considerate of the member impact in ways that the congressional proposal may not. And we really believe that we will achieve a better outcome for individuals if there is this timing, the difference around timing, whereby the person can first become Medicaid enrolled and then fulfill those. And we can coordinate the activities in alignment with our SNAP program, but also coordinated effort with our contracted entities as far as our managed care plans and other contracts that we may have, as well as our partners at DWS who are doing these engagement activities and helping people with the work requirement pieces, that we believe we could be more successful if we were able to do that after. So we're really emphasizing this. The other piece that we are talking about is looking at the definition of employment supports and what Medicaid can be reimbursed for today, and really asking for a broader lens or consideration of how employment supports could come together. Today, Medicaid can reimburse for employment supports for very narrow populations, and we are asking for a broader lens around employment supports in order to be able to use Medicaid funding for this administrative activity and to be able to pull down the federal dollars as well in order to really build up a robust employment supports pathway for individuals. So as we look at the differences, and we've done some comparisons of the proposal that first was in the House but now the Senate and has come out of the Senate, and then the one that Utah has drafted, really as it's come down to the final wire, as we're really thinking of where we can potentially influence change. We are really leaning into the timing of work requirements as our primary focus. And then certainly as we're meeting with CMS as well, and we can carry this discussion into future months as well, is really looking at that definition of employment supports today. So I'll stop with that and just say that's kind of where we are with regard to our differences. And then if there's any questions, I can take those, and then I'll move into what our next steps are with our 1115 waiver. Okay, having none, then what I'll say
sorry.
we're doing. Oh, sorry,
Jen.
Rachel. Go ahead.
No, that's okay. I couldn't find my unmute button. My bad. So I just have something that I kind of want to flag, and this is like kind of maybe a little bit nitty gritty and more in the implementation phase. But should everything go how we think it's going to go, I guess I should say. One thing that I wonder if there's a way to, and this is something that I might talk to some legislators about as well, to tweak the ESI requirement, especially if someone has like an exemption, that they not have to go through the ESI process as well. Like it would like auto basically opt them out, because at that point, like, you know, that they don't have an employer, if they're exempt, that they don't have an employer to ask for, like just little things like that. If there's ways to like streamline everything all together, and I know this is part of the like timing of, and why this is going to be difficult for states to process a work requirement. It's going to like feed into a lot of different things, and not just the ESI form. Obviously there's other forms too, but if there's like processes there that, like, I don't know, I'm kind of talking in circles, but I think you know what I'm talking about. Like if part of this can speed up other requirements under the Medicaid program, that would be great.
Yeah, thank you for the feedback on that. And I think there's, you know, if that's something to prioritize now, Rachel, and something you feel is like a priority you want to take forth and talk about, we'd be happy to talk at greater length about this and about your ideas. There's certainly a deep dive we're going to have to do when it's time to implement this work, that the team will be very focused on. And I think we need to, you know, tease out all these different details and think about how we can create the greatest administrative efficiencies.
Yeah, this could be, I think, maybe a good thing for the back to look into as well, probably.
Sure. Yeah, we're happy to take that feedback. Thank you for the suggestion. Okay, so I wanted to wrap up before we move into some of these other pieces, please, that oh, certainly. So to address the conflict of interest form that was addressed, and I missed some of the federal update call that really detailed this week, Russ. But one, I believe what the provision was looking at, and some of the team may want to help me with this one, is that managed care entities are not allowed to attest on behalf of a member, is the provision. That I know managed care entities are seen as folks, individuals who can, and organizations that can help support the member in fulfilling the necessary components of work requirements, and maybe even help with exemption status and things. And they are used as navigators and other supports today. However, they are not allowed to be the official voice of the exemption or attestation on behalf of the member, I believe is what that provision was getting at. And I see Michelle nodding her head. Okay, thank you. So I think that's what it was, that, you know, like, let's say a physician can attest to the member's medical needs, for example, but the managed care entity cannot be the one that would attest. You can provide information and help support, but you cannot be the attestee. Okay. Let me walk through what we are doing with our 1115 waiver, and then I will maybe just spend a little bit more time here talking about these other provisions. Quickly on where we are with our 1115 work requirements waiver that has been drafted. So we completed the public comment period on June 2nd, and we had about we had 260 comments that the team has synthesized and has gone through a comprehensive review of every comment. We have drafted responses to each of the comments, and some are the same comments. So we've bundled where they are the same or very, very similar, aligned, so that we could have you know, a little bit of streamlining there. That is now moving its way through my review, and we are also making some modifications to the waiver in response to our public comments. And so with these updates are complete, our intent is to submit our waiver to CMS. And within the next 2 weeks, so by the end of the month, our goal is to have the waiver submitted to CMS. And having met with CMS last week on this, our intent is to be at the table in discussing what the plan of action should be when the congressional bill is finalized. Our goal all along, we believe that the provisions that Utah has drafted, and while, you know, we're still working to see if we can perhaps influence the language that's moving through Congress, there's a lot of language that needs a lot more refinement, and there's a lot of work that is just not covered in Congress. Like, the Congress will hand the bill, the president signs it, they'll hand it over to CMS and say, okay, now write the rules, and they have to interpret all of this for states to be able to implement this work. It will require CMS to work closely with some states, and they've already stated that they would like to work closely with some states in order to define what these mean, and also really look at feasibility and best practices for maybe even implementation from a systems perspective, policy perspective, and operational perspective, as well as coordinating with all the other associated parties that you know, are outside of Medicaid too. And so, you know, our communication and my communication to, you know, CMCS director last week was that Utah wants to be one of those states. We want to work closely. We would like to do this. And what we were told is that CMS, once they pick these states, will come visit and spend time with the state and deep dive into systems and programs and things. So that's where we are, and our intent in submitting our waiver is to flag our interest in participating in these conversations. And so that's where we are. Once we submit to CMS, there is still, first of all, that document becomes public. So there's an opportunity at that point to see what updates we have made to our waiver because of public comment, and also review the responses that the team has drafted and that we have completed with regard to those public comments. CMS will also do a 30-day public comment period on the Utah waiver, and they will post that on their website and put out a notice about that. But there's additional time for the public to give comment to Utah's proposal at that time if people are interested. So that's the timeline we're working on. That's kind of why we're putting our foot forward, is because we would like to partner with CMS on this work. And so wanted to share that with you. We certainly don't know, like, the bill is not final. It may be done in a couple weeks. It might take longer than that. But certainly that's kind of where we're at today. Okay, with that, I'd like to suspend a little bit time, and I don't know, you know, Michelle, would you like to just take a quick moment to touch on these, since you're much more savvy at these changes than I am, and just call out these new provisions, please?
Yes, these two that you have presented.
Yes, please.
Right?
Mm-hmm.
Yes,
Yep.
Absolutely, Jen. That's fine. So I think this first one, just a simple explanation of this section 71110. What they have done is just basically amended and narrowed the definition of a qualified alien from current law. And with that, so refugees, humanitarian parolees, asylum grantees, certain abused spouses and children, trafficking victims, and certain other non-citizens would no longer be considered qualified aliens for purposes of Medicaid and CHIP. I think another note that you have on here as well, Jen, this also has an impact on that definition under the marketplace coverage. So what this might mean is restricted eligibility under the marketplace for these individuals as well in receiving advanced premium tax credits and those types of benefits. For this second section 7112 expansion FMAP for emergency Medicaid, the gist of this one, so under the adult expansion Medicaid, if someone qualifies for that category, and they're eligible for the emergency benefit package only based off of their status, it just reduces the state's federal match rate for that program. So it doesn't indicate that there's any reduction in benefit or anything like that. It just reduces our match rate for the state. And Brian, if there's anything that I've missed on that one, please chime in, but I think that's the gist of that second one, Jen.
Yep, that's great.
Okay.
Okay, let's go ahead 2 more slides, please. And I'd like to just call out, I've covered the retroactive Medicaid CHIP coverage. Let's go to the next slide, please, and I think we can wrap it up. Just to remind as well, these were not changes from the House to the Senate version, but still important to call out that this does change Medicaid eligibility reviews for adult expansion, which would also include TAM, to every 6 months instead of annually. So wanted to just say that is still at play, and that has carried forward. It's also looking at the emphasis of this administration on fraud, waste, and abuse. It does require us to establish a system to identify duplicate enrollment and cross-state enrollment so that we can look at where people may be enrolled in multiple states and address that. So we have to look at the change of address database and put that in place. We're already working on some of these things. And then certain things around member and death files and also provider death files as well was included in there. Okay, I think I'm going to wrap it up here. Is there anything I just want to see, Brian, is there anything, Brian, that you think is notable to call out? There's a lot of text in this slide deck. We'll share it with you. We know there's a lot of things happening, but also at the same time, this is still an active living bill, and it's still potentially subject to some changes. So we can bring the final package forward. But Brian, do you think there's anything else to call out that we haven't addressed?
I don't think so. Just, but yeah, just to reiterate for the group, we're continuing to track as much as possible, and our national partners, the National Association of Medicaid Directors, are helping us and all states be aware of the process. So it's still a lot of Senate deliberations that we're tracking, and going to track up to the Senate vote that we're expecting any day.
Thank you. Last thing I'll say, and Sharon, you can close this slide deck. Thank you for presenting it. Last thing I'll say is there are defined dates of implementation for each of these provisions. So some of these, whether it begins at the date that the bill is enacted and many dates staggered over years based off of each policy update. And so I think for us, it's our objective to be as organized as possible around this and create a comprehensive project plan and assign staff and individuals who will be leading out on this from the start, because some of this is a big lift within a very short period of time. And so we're already beginning that work, and I think really mapping it out and understanding how they all interplay is something that we'll be spending the next few weeks on. Okay. Thank you very much for that opportunity. Now we're going to go through some policy updates, and I think that will wrap up my portion. Right now, Sharon, do you mind displaying the 1115 waiver and policy update slide deck if you can?
Yep, just give me 1 second.
problem, and I'm sorry, my internet I'm on a hotspot today, so I didn't want to display from my own screen. Couple things I'm going to call out. July 1 is typically a big policy month for us coming out of legislative session. We often see many different changes happening on July 1. What we're going to be presenting today are some higher level policy changes. We certainly have numerous rate updates that are happening this month, and so those types of things and other smaller policy items will be implemented. So this is not a complete list by any means, but what I'll go through at least in the next slide after the 1115 waivers, we'll cover some of those. So what we wanted to share with you first of all are some pending 1115 waiver amendments that we're working directly with CMS on right now with an anticipated approval date of fall of 2025. There are two specific policies we wanted to call out that we expect approval of. They've bundled together several different policies that are a little bit smaller in scope and don't require a lot of back and forth with our federal partners. And so these two that are selected here, while one of them you may say that was just through session this year, it's considered a smaller lift with regard to policies, which is why CMS has put it kind of at the front of their reviews. But first and foremost, I'd like to just cover family planning services. So for individuals who are above the Medicaid income limit and up to 185% of the FPL, this waiver would allow access to individuals to be able to get coverage of family planning services. This is for family planning visits, contraception, as well as different vaccinations and lab test supplies as laid out there, including also testing and treatment for STIs and sterilization procedures. So it's a comprehensive family planning benefit that I know some of you may have worked hard to get this in place. And so we do anticipate that we will have approval of this sometime in the fall of 2025 with the hopes of implementing it in probably early 2026 or when we can get these things programmed. Next is a waiver that we are actually getting ready to submit to CMS this month, which is to transition our pediatric and postpartum dental services from a managed care delivery model to the fee-for-service delivery model that's administered through the University of Utah School of Dentistry Associated Provider Network. And so this was put forth as a state savings proposal this past legislative session, and it passed, and CMS believes that they can do the work on this waiver pretty efficiently, expeditiously with us, and we do see approval of this and expect it this fall. We would not implement this change until next year, and we're thinking about July of 2026 for this one. We do have several other waivers in queue, but these two are policy changes that we expect approval of in the fall. Next slide, please.
Yeah.
Wanted to cover, yes.
I have a quick question on the family planning waiver. Will that be subject to the same application as like a normal, a non-limited benefit? Like, do you know what I mean? Like, is it the same exact process for approval as like if someone was applying for the entire Medicaid program?
Michelle's saying yes. So yes, go ahead, Michelle.
Yes, that's a great question, Rachel. And yes, and the reason for that is because obviously we would screen that individual to see if they qualify for full Medicaid first, right? And so we'd be requesting information and stuff like that. So it would still be the single streamline application. Yes.
Okay. Thank you.
Okay, thank you. Next slide, please. A few policy updates we'd like to cover. First of all, wanted to announce that on July 1st, we will be expanding the provision of free care, as it's been historically known, to our Medicaid enrollees, so that children who are Medicaid eligible in the school-based setting are now, those services can be billed to Medicaid from the local LEA, so at Local Education Authority. So with that, today we have a limited benefit we benefit with services that can be billed to Medicaid in the schools for individuals who are on an IEP, and this will expand those services, which are listed here, that can be billed to Medicaid for other Medicaid enrollees as well. And this is not an exhaustive list. These are just some examples of what could be billed by the schools. We know certain also behavioral health services can be billed as well to Medicaid through this program. And I know that's a focus as well. And so if you have school-based providers who are delivering certain behavioral health services, those as well would be included. Yes, Brian, let me see a nod of yes. Yes, thank you. Okay, but it's not on the list, but wanted to incorporate physical health and behavioral health are also kind of wrapped up in this, and oral, even maybe some oral health if it's in the school, but
yeah,
go ahead, Brian.
Exactly. Yeah, the items highlighted here are just additionals beyond some existing care that will be served, but what the new expanded care will do, it will both make more children available for that Medicaid reimbursement and more services for both the existing children eligible under the school-based services and the new children that are eligible to receive these services. So yeah, a win-win there.
Yep, and we've been working with our schools for a while now to educate them about this. This is optional. Schools do not have to participate in this, of course, but we do have LEAs that are very engaged and are looking forward to doing this. But we do, we do have the education that's already been delivered to schools, and they're on board with this. So for this coming school year. And go ahead, Thais.
Thanks, Jen. This is exciting. I was just wondering, do we know which LEAs will be taking on SBS?
Do you have that detail, Brian?
We have yet to get firm commitments. What we're doing is sharing with them the ability for them to model the amount of reimbursement that's newly available to them based on the services that they provide. A lot of them are engaging with us on that and learning more, but we haven't yet defined the list of local education agencies that are going to participate yet, but we're encouraging them.
Thank you. Appreciate that. Thanks.
Mm-hmm.
Okay, thank you. And next item I wanted to mention was the expansion of our housing related services and supports. This is a really wonderful program that served, I think, 1,000 TAM members at this point from the targeted adult Medicaid population. And certainly we've seen the benefits of HRSS and the scope of the services that it's provided as a really positive pathway for even hundreds of individuals who are getting HRSS to be moving into permanent supported housing from this benefit as well. What we're seeing with this here is that this will be expanded to all adult expansion members effective July 1. And so there will be more individuals who will be eligible to get this at that time. And we certainly have been able to make our network of HRSS providers aware of this. And I think we are still bringing on new HRSS providers to meet capacity for the needs of the community, but we certainly have a lot of providers on board now who are providing the services. And certainly Brian oversees the office that manages this work, but we've been also bringing on more providers who'd be able to provide HRSS services. Brian, would you give just a quick moment or two around the case management services and how we work closely with the Housing Authority and the member and to just coordinate that work?
Yeah, absolutely. We've actually done some kind of innovative things over the last few months and plan to again later this year, having actual HRSS provider summits that have helped us tremendously so that our HRSS providers can learn from each other. A lot of them, when adapting to a Medicaid billing structure where procedure codes and diagnoses are required, it takes some work, but our program experts and Chris and Linda have worked really fostering provider partnership to help them understand the documentation requirements, helping them to understand the available services. The new services for adult expansion is going to be slightly different than For targeted adult Medicaid, individuals here know TAM members get 12-month continuous eligibility. So one of the changes with expanding to adult expansion is the eligibility lookup tool has to be a matter of their process. So we're developing more education materials, doing outreach to the providers so that they understand how to do those eligibility lookups and navigate the housing plan in light of that eligibility. So a lot of work to do, but we are thankful for our HRSS providers and always looking for more partners there.
Thank you, Brian. And just in the context of some of the proposals and the challenges Brian called out with regard to enrollment for adult expansion, we see again the 12-month continuous enrollment has been a real benefit for the HRSS program, and certainly engagement of the providers in providing the HRSS benefit, and certainly with a 6-month eligibility review. We know that's kind of a shifting environment we're going to have to navigate as the program and maybe some of these services have to be like modified a bit. So I'm just working with the providers through these changes. So, okay, thanks for calling that out, Brian. That's the last bit of slide that I had for you, but I wanted to just verbally mention something that we talked about previously is that medical respite benefit, which is for adult expansion and TAM members, which allows up to 60 days annually, I believe 60 days, that an individual is able to get an overnight stay and a home health level of care at a facility to meet their needs following a release from hospitalization or nursing home, for example, and would otherwise be discharged to homelessness. And so this was an RFP and the solicitation has been closed. We have not yet announced the recipients of this, but there will be 2 providers who will go live with this program in upcoming months. And so we are excited to finalize the procurement on this and get moving forward with this really valuable benefit for Medicaid members. Okay, wanted to just call out 2 other things that we didn't have on the slides, which with regard to changes to the pharmacy benefit. One thing I'd like to call out around psychotropic medications. For many years, since psychotropic medications were added to the pharmacy preferred drug list, there has been an override process so that people could get the preferred or the non-preferred. In fact, and specifically, they could get the non-preferred psychotropic medication by the provider prescriber writing dispense as written on the medication prescription. And so for these medications, it's been able to kind of bypass that preferred status indicator and allow the person to get a non-preferred just by the provider writing DAW1 on the prescription or dispense as written. This is going to change on July 1 for psychotropic medications, and specifically the psychotropic classes I'm talking about are antidepressants, anxiety medications, ADHD medications, and mood stabilizers. That these medications will require a trial of the preferred drug before a non-preferred drug will be approved by the pharmacy team. We are putting a grandfathering clause in place so that anybody who is currently maintained on a non-preferred drug, they can still continue on that without interruption. And so that will be programmed into the system so that individuals who may be on a non-preferred drug can get that, can be grandfathered forward on that. Additionally, there's still always the prior authorization pathway that if a person was on a non-preferred drug and is maintained on that, they can qualify for continuation of care and get the non-preferred drug. But wanted to just mention that bypass is going away for new prescriptions. The second thing I wanted to call out that came through this past legislative session was funding for GLP-1s for the purpose of indication, I should say, of obesity or meeting the qualifications of being overweight without cardiovascular complications. Today, we cover GLP-1 drugs for individuals who do meet cardiovascular and other MACE indications, but they are not covered for the purpose of weight loss alone when you do not have complications. There was a limited amount of funding that was put forth for 1 year. So one-time funding that was put forth to cover these products, and we have agreed to open the GLP-1 medications for this indication in the fee-for-service population only because of the limitations around funding. So they're not available through the ACO benefits, but they are available through the fee-for-service enrollees, and that will be starting on July 1 as well. And we will be able to cover these products and currently have funding for 1 year. With that, I think that wraps up the updates we wanted to share with you today. We can take any questions or just thank you for your time. We will be sharing the slides that we've put together with you, and so you'll be able to have those, and happy to follow up on any questions you may have. Okay, thank you.
Thank you, Jen. Okay, I think our next item is number 7. We're gonna have like an overview introduction to, I don't know how we want to classify it, to the Behavioral Health Commission, and that's gonna be Mia Naffinger. Mia, I've heard your last name before, but I know I just pronounced it wrong, so my apologies.
Can you hear me? Sorry.
Yes. Yes.
Okay. Yeah, it's Mia Nafziger. It's definitely a tricky name, and I am sympathetic to the struggle for that. Let me pull up my slides. Okay. So thank you all for letting me join you. My name's Mia Nafziger, and I am the staff administrator for the Utah Behavioral Health Commission. And I'm going to be giving you some updates on what the Behavioral Health Commission has been up to, and then talk about how that intersects with Medicaid specifically. So starting off, the commission is really rooted in the Utah's Behavioral Health Master Plan, which I imagine many of you played a role in the creation of this plan. It came out last year in January in 2024. And this document was created to act as a guide for stakeholders on what we need to do next to improve behavioral health. Some of the challenges that the plan identified that we see in behavioral health are that our providers are facing a really significant administrative burden with insurance. We see siloed approaches, so a lot of different groups across the state in different spheres working on behavioral health, but those efforts often overlap. We're seeing shortages in the workforce and limited funding levels across all types of behavioral health care. And so the master plan identified 7 strategic priorities for the state to consider that we can use to improve our system. And those are here on the slides. You can see they relate to evidence-based interventions, prevention and early intervention, the integration of physical and behavioral health, improving navigation for patients and families, continuing to build out our crisis system, improving supports for people with a serious mental illness, and finally expanding our workforce. And so the commission really came out of that master plan. So the Behavioral Health Commission is the central authority in Utah for coordinating behavioral health initiatives across the state. And it was created by Senate Bill 27 in 2024, so just after that master plan came out, and the commission has been actively meeting since July. I think one thing that I'm going to stress here, and it'll come up later again, is that the commission, so I act as staff for the commission, I support them. All of the commissioners themselves are independent from our state agencies, so independent from the Utah Department of Health and Human Services, independent from our governor. And while staff like myself who work at DHHS do provide support, the commissioners can make independent policy recommendations. And again, the commission is really here to improve coordination in our system. These are some of the statutory duties that are required of the commission, and I'm not going to go through all these, and this isn't even the full list, but it includes making recommendations on behavioral health to the state, engaging with the private sector. So the commission is really a public-private partnership, continually reviewing and revising the master plan, and we're going to talk about that in a bit. And they're also specifically called out as overseeing our behavioral health workforce initiatives, and suicide prevention efforts. These are the current 11 members of the commission. You can see we have folks with a range of backgrounds, people named specifically because of their lived experience, public and private. One thing I would definitely call out here is that you can see Director Gruber of DHHS is a representative on the commission. And so you have Medicaid represented in that way. And then we also have several folks who represent the county Medicaid behavioral health perspective. So there are members of the commission who directly oversee our Medicaid programs. This chart is a little wonky, but the reason I like to include it, it has all of the different subcommittees that the commission oversees. And you can see they are working on a range of issues. So we have groups who are focused on crisis, focused on prevention, the workforce, suicide prevention, treatment, and this really shows that there's a wealth of subject matter expertise within the Behavioral Health Commission's work, and that can support them in their recommendations to the state. There is also a legislative policy committee directly connected with the Behavioral Health Commission, and that is made up of 5 legislators. This is kind of a unique piece of the commission structure, and it means that the commissioners have a really direct link with their legislators. The legislators can assist the commission with their recommendations, but they also review recommendations from the commission. And we're going to actually talk about that. I think it's the next slide. So last session, 2025, the commission had a set of 14 behavioral health recommendations for our legislature. And these are all listed here, and they ranked them in terms of highest to lowest priority. Representative Elison, who is one of the members of that legislative policy committee, really took on the mantle of the commission's work, and he developed HB 491, which originally had all of the Behavioral Health Commission's recommendations. Ultimately, the bill did pass, and what I have here is the pieces of the bill that actually made it through. So not every recommendation made it through the legislative session. But, I would call your attention here that 2 provisions that remained were 2 increases for Medicaid rates for peers and for mobile crisis outreach teams, both of which are really key elements of our behavioral health system. And if you go back to that table, this has in green all of the different recommendations that did ultimately pass through. You can see number 1, the update to our Medicaid consensus process. That really has provided more stability to county behavioral health Medicaid services. And that was not actually passed through legislation, but the commission was really excited that that change happened. So I mentioned how the commission is responsible for continually updating the master plan. One of the major priorities of the commission right now is it is developing a strategic plan that builds on the master plan. And the reason that's important, the master plan had over 200 recommendations. It had a lot of great ideas, but we likely needed a more specific and actionable document. So right now, the commission just wrapped up its listening sessions on its draft of the strategic plan. And in July, they will vote on that plan. And every year, the commission is going to update it, but it really outlines specific tactics, data that we will be tracking, and our top priorities. So the plan is not comprehensive of everything the state is doing in behavioral health, but it's meant to highlight here are the areas where we see the greatest gaps and where we need to focus. And we're trying to center the plan in data, measuring our progress and ensuring we're picking the right priorities based on what the data is showing. These, I'm going to just showcase a little bit of the plan, but not too much. These are the high-level population indicators that the commission is tracking in that plan. So you can see they're tracking the prevalence of substance use disorder and mental illness in Utah, our youth need for treatment, drug overdose deaths, deaths due to suicide, and the rate of 9th through 12th graders who indicate 3 positive childhood experiences. And they are also tracking a host of other metrics. If you go to our website, which is linked in this PowerPoint, you can see a beautiful data appendix with great behavioral health data that we are tracking. These are the 4 major strategies of the plan. So prevention, early intervention, crisis, treatment, and recovery. And yeah, I just was checking my slides. So I'm not going to go any further, but if you go on our website, you can go in and see the specific objectives and tactics that are under this, and it gets quite granular in what the commission is planning to do. And so that information is all available online. The other piece of the commission's work I wanted to highlight today is that every year the commission, as I showed you last year's legislative recommendations, they will also be providing recommendations for our 2026 general session. And I actually just stepped out of their meeting where they have been discussing what those recommendations will be. And they haven't finalized their list or what their priorities will be, but they're considering options related to crisis services, infant and early childhood screenings, peer support, school-based mental health services, suicide prevention campaigns and trainings, and the capacity of Utah State Hospital. So it's a lot of information on who the commission is. How do the commission and Medicaid intersect? First of all, the commission, while Medicaid is a state program, state and federal program, the commission is an independent entity, but it includes members who oversee Medicaid programs. So there is a really direct linkage there. The commission also is responsible, as I said, for coordinating behavioral health initiatives across our public and private sectors. And so that includes coordinating efforts with Medicaid in behavioral health, with the physical health, or excuse me, not the physical health side, the private side. And so the commission really wants to work in partnership with Medicaid on that, as well as the third bullet you can see related to the vision for Utah. So the commission, its strategic plan is laying out the vision for our state in behavioral health, and that obviously overlaps a lot with ongoing and future activities within Medicaid. And then finally, the commission makes legislative recommendations. Medicaid often has its own legislative priorities, and I think we see that those often align in behavioral health needs. This slide has a few of the specific areas of overlap in behavioral health policy I think we're seeing right now between Medicaid and the commission. So for example, the commission has a tactic related to expanding reimbursement for coordinated specialty care for first episode psychosis. And this is an approach already used in Medicaid, and there's an interest in expanding that reimbursement approach to the private sector. I think there's also an interest in thinking about how we can reform payment for crisis services. Medicaid has obviously prioritized the integration of behavioral and physical health, and the commission has as well. It has an objective related to that work. And both Medicaid and the commission are working to support our behavioral health workforce. And again, you saw that earlier in the slides where the commission has supported Medicaid rate increases for certain behavioral health professions. So finally, how can Medicaid and the commission collaborate in the future? I think it's key to note that Medicaid has really direct control over the coverage and reimbursement it provides. It has quite a bit of control over the ACOs it oversees. The commission is purely advisory. It does not have the ability to hold entities accountable. So Medicaid has some levers there that the commission does not. On the other hand, the commission works really closely with the private sector and is really meant to be a public-private partnership. And so here we see opportunities to expand best practices in Medicaid to the private sector. I already mentioned one of those, and I think we can also see that going in the other direction. In addition, in terms of legislative priorities in behavioral health, I think when Medicaid and the commission are aligned, those voices, the voices will amplify each other, and there's a greater likelihood that those behavioral health priorities will make it through the legislature. And then finally, the commission, as I said, is statutorily independent from the governor and from DHHS. So it has some freedom to make independent recommendations that Medicaid does not always have. So that was quite a bit. If you would like to learn more about the commission, our website has all kinds of information. You can submit feedback on our website, and our meetings are open to the public. Our next meeting is Thursday, July 7th, and the website has all of the details. And I guess I will pause if there's any questions or comments.
Okay, hearing no questions from Mia. Mia, thank you for that presentation. That was very helpful, at least for me.
Of course.
And then I think we can move on to our second to last agenda item, which is committee member updates. So I'll pause for a second if anyone has any updates, requests, etc. Okay, again, hearing none, I will pass it over to Sharon to talk about the results from the budget vote.
Okay, thank you. So I appreciate it. Hopefully you can hear me okay. So I have tallied all of the votes that the MAC committee members have submitted to us. Again, these are going to be submitted to the department for their consideration for the FY27 budget. And I will read these off one by one so that those on the phone and who may not be able to hear or to see the screen so that they can hear what the votes are. Okay, and so with the voting, so the MAC members voted from 1 to 13, and the lowest, so 1 is their highest priority. So the lowest score means the top priority for the department's consideration. So here we actually have a tie for first with a score of 56, and that is the developmental disabilities system and the new choices waiver increase. In second, we have infant and early childhood mental health reimbursement with a score of 61. In third, we have the mental health system with a score of 62. Fourth is the employment-related personal assistance services, the EPAS case management rates with a score of 83. Fifth, we have the support coordination external rates with a score of 100. Sixth is the refractory epilepsy patients with a score of 107. And seventh, we have the rate increases for incontinence supplies, non-waiver nutritional drinks, and other soft medical supplies with a score of 112. Eighth, we have the lowering Medicaid's dental anesthesia costs with a score of 115. Ninth, we have tumor treating fields therapy with a score of 123. 10th, we have the Foundation 1 CDX and Foundation 1 Liquid CDX with a score of 127. In 11th, we have the cranial remolding orthosis with a score of 133. And 12th, we have the ColoSense performance data, a new era in stool-based CRC screening. I will, along with the slides that were presented today, I will send this out in an email to you all so you have it. Yeah, and that concludes the results of the voting for this year. Thank you.
Thank you, Sharon. All right. If no one has any questions about the vote, I think we can adjourn. Our next meeting is on August 21st, 2025 or I don't know why I had to say the date. It's August 21st, from 2 to 4 p.m. unless, as a reminder, anyone wants to request an earlier meeting, although I do believe usually July is a pretty light month attendance-wise. If we've ever had, I think we've skipped July in the past. So speak now, otherwise we will see you in August. And I think we're all set for the day. Thank you all and have a good rest of your week.